Our learning objectives are to talk about some congenital heart lesions that may present for the first time in the adult patient, review some common presentations of those patients who have been previously palliated, and understand when to refer to an ACHD specialist. So congenital heart disease is the most common type of birth defect. It affects about 1 in 100 births. And currently there are more adults than children living with congenital heart disease in the United States. Some of these lesions may present for the first time in the adult patient, and when these patients present, they have very nonspecific symptoms and they can have very subtle exam findings. So it's really important that we understand how to recognize and perform appropriate testing to make the diagnosis for these patients. One rule of thumb is to remember to always exclude reversible causes of either hypertension or pulmonary hypertension. In a patient who previously was palliated with some form of complex congenital heart disease, they often have significant residual anatomic and hemodynamic issues even when they don't have symptoms. So it's really important that they're being followed with appropriate imaging and testing to make sure we pick up abnormalities before they end up with complications. The transition for our patients from pediatric cardiology to adult cardiology can be challenging for a variety of reasons. They may not have access to a center with adult congenital heart disease, and there's actually a limited number of specialists with training in congenital heart disease, but a large number of patients with a growing population. So it's really important that we can work together and collaborate with local cardiologists, with primary care providers, and with other subspecialists to make sure we're giving these patients appropriate care. The guidelines for management of patients with congenital heart disease were updated in 2018. The biggest change to the new update was the incorporation of this ACHD anatomy and physiology classification. The understanding here being that a patient can have the same anatomic defect but can be very functionally variable in their presentation. And so this document provides recommendations regarding the timing of follow-up for routine evaluation and the types of testing that need to be performed on a regular basis. It's also important to recognize, and is highlighted by these guidelines, that outcomes are better for these patients when they're cared for at an ACHD center. So it's really important that we collaborate care and make sure we're providing high-quality care for these patients. So let's start with a case. It's a 33-year-old man who presents to the emergency department with palpitations and near syncope. So he was previously asymptomatic, playing soccer, doesn't feel there's been any decline in his functional capacity, and he has no chronic medical conditions and is on no medications. On exam, he's mildly overweight, he's not desaturated, he's got a systolic ejection click and a 3 out of 6 systolic ejection murmur radiating into both lung fields, and otherwise no signs of heart failure. His electrocardiogram shows sinus rhythm with a right bundle branch block. And his chest x-ray shows several findings that I want to highlight. So you can see pretty significant enlargement of the right heart, both the right atrium and the right ventricle. You see dilatation of the pulmonary arteries. You actually see a lot of pulmonary blood flow out into the lung fields. So the patient was referred for an echo, and the left heart is normal. The striking abnormality is the severe enlargement of the right ventricle, but with normal function. His pulmonary valve domes, you can see nicely as it opens the doming with flow acceleration by color Doppler and a mean gradient of 38 millimeters of mercury. From subcostal imaging, it was pretty challenging, but you can see the atrial septum looks very redundant. It looks like there might be some dropout here, but it's pretty hard to see. And with color flow, it's actually, I would say, pretty challenging to know how much shunt is present here. This was the final report, which was read as severe pulmonary valve stenosis with that mean gradient of 38, severe right ventricular enlargement. The RVSP was reported at 67. A couple important things here. This does not represent pulmonary hypertension because we have a gradient through the outflow tract. And also this is probably underestimated because our gradient across the valve was 65. And then this note about an atrial septal aneurysm with what was called a small left to right shunt. So if you're seeing this patient, what would you do next? The incorrect answer would be to send the patient for pulmonary balloon valvuloplasty, which is what was referred in this case. So the important teaching point here is that this patient has a large atrial septal defect. So this is one of the diagnoses that is commonly diagnosed for the first time in the adult patient. And presenting symptoms may include things like a murmur, and the murmur is due to increased flow through the pulmonary valve, not due to shunting through the atrial septal defect. Patients are often short of breath. because they can develop pulmonary hypertension, or they can present with arrhythmias. Important to remember that ASDs cause right heart enlargement, and so if the right heart is big, that suggests that there's a significant volume load and the ASD should be repaired. That being said, if you're seeing a patient with a really big right heart but you don't identify a shunt, you need to perform additional imaging to rule out an ASD. Also important to remember that pulmonary stenosis causes right ventricular hypertrophy, not right heart dilatation. That's how when we met this patient, we knew that this was not primarily pulmonary stenosis because that should not cause this degree of right heart enlargement. So this is our patient's TEE images from intraoperatively, and so what you see is a very abnormal atrial septum with multiple fenestrations and very, very large left to right shunt through these different defects. So this patient underwent patch closure of the atrial septum. The pulmonary valve was inspected and there was no significant stenosis. And the dismissal echo showed no residual shunt, RV pressure down to 27. And remember, I showed you that pulmonary valve domed, so there was very mild stenosis with a mean gradient 2 meters per second and a mean gradient of 9 millimeters of mercury. So just one slide here about pulmonary stenosis. So this is usually in the setting of a tri-leaflet valve, and the commissures are fused, and that gives this doming appearance similar to the patient that I showed you. On exam, they'll have an ejection click and a murmur. If they have severe pulmonary stenosis, they can develop right ventricular hypertrophy, and you'll see that on the ECG. On chest x-ray, the right heart should be normal, but you can get dilatation of the main and the left pulmonary arteries. And if you see mild pulmonary stenosis in an adult patient, it's rare that it progresses. So only a 20% chance of progressing if the maximum gradient's less than 50. But if the gradient is high, these patients usually do need intervention, and our first line is usually a pulmonary balloon valvuloplasty. So just 2 chest x-rays to drive home the point here. So this is a patient with pulmonary stenosis, normal right heart, dilated main and left pulmonary artery, not much pulmonary blood flow, as opposed to this ASD where you've got right heart enlargement, right atrium, right ventricle, big PAs, lots of pulmonary blood flow. So nice differentiation here between the two. And this is how in our patient we knew that it was not predominantly a pulmonary stenosis, but it was an ASD causing a chest x-ray that looked like this. So I want you to also recognize that anomalous pulmonary veins cause the same physiology as an atrial septal defect. So if you're seeing a patient with a really big right heart, but you don't see an ASD, maybe you do a bubble study and you don't see any bubbles, then you need to think about anomalous pulmonary veins. And these are best visualized with cross-sectional imaging. So here you see an image of an MRA in a patient with scimitar syndrome. So you see all of the right side of pulmonary veins are connecting down here to the IVC. If the patient has significant right heart enlargement in this setting, then you need to repair them, and the type of operation really depends upon the location of the connections and the types of connections. And so we need this cross-sectional imaging. Down here I'm showing you a sinus venosus ASD, so you see this connection right here between the left atrium and the SVC, and then this pulmonary vein connecting to the SVC up higher. So one slide about VSDs and PDA. So it's going to be really rare for you to see one of these diagnoses in an adult patient. Both of these defects cause very loud murmurs, so they're typically picked up in children. Both of them cause left-sided chamber enlargement and pulmonary hypertension. So if a patient has a VSD or a PDA of even moderate size, they're going to develop significant pulmonary hypertension within the first year or 2 of life. If you do see a patient with one of these diagnoses, it's usually someone who was diagnosed with a small VSD or PDA as a child and was told that intervention was not needed. It might be a patient who really hasn't had any limited or has had limited or no prior medical care, so no one's picked up on the murmur. And if that's the case, oftentimes patients are going to have Eisenmenger physiology or severe pulmonary hypertension from the shunt. And I'm just showing you here 2 examples. This is a small membranous VSD with left to right shunt, and this is a PDA right here entering the main pulmonary artery, just to show you what those look like with echo. Let's do another case. A 48-year-old woman presents with exertional dyspnea and hypertension, which was actually first diagnosed during pregnancy in her 20s. At that time, she had an evaluation with an echo, which showed a bicuspid valve. She's had significant hypertension despite 4 medications. Her additional workup showed no evidence of renal artery stenosis and no pheochromocytoma. On exam, her right arm blood pressure is 160/90, and she's got a systolic ejection murmur. So she's referred to the echo lab, and I'm going to show you here suprasternal imaging. So this is the aortic arch, and with 2D imaging, you can see an abnormality right here. With color flow imaging, we see flow acceleration right at that location. Our continuous wave Doppler showed a mean gradient through there of 43 millimeters of mercury. And our pulse wave Doppler of the abdominal aorta is abnormal in a pattern that is consistent with coarctation of the aorta. So this is our patient's MRA. Our patient has coarctation of the aorta, which is a discrete abnormality in the proximal descending aorta. It's relatively common, about 5 to 8% of all congenital heart disease. It is more common in males than females, and important to remember that the majority of patients with coarctation will also have a bicuspid aortic valve. And they can also have multi-level left-sided lesions, the so-called Schoen's complex. Now, this is one of those things that you would anticipate would be picked up in childhood, but not infrequently we see it in adult patients. Here's another patient of mine that I saw recently, a man in his 40s who presented with a nearly interrupted aortic arch. So typically patients present with hypertension from a very young age. They may have headaches or nosebleeds or lower extremity claudication. If you do a good exam, you'll note decreased pulses in the legs. There'll be a radial femoral delay. And if you take a blood pressure in the arm and the leg, you'll see a significant discrepancy. On exam, they might have an ejection click if they also have a bicuspid valve, or they might have a murmur over the upper back from flow through that coarctation segment. One clue in the adult patient with long-standing coarctation is rib notching, and so you can see that here. You get these notches in the underside of the ribs due to the presence of collaterals. And if you're an echocardiographer, this is the most important slide for you when it comes to making the diagnosis of coarctation. So when we do a pulse wave Doppler of the abdominal aorta, a normal signal has a rapid upstroke, a rapid decline, and an early diastolic reversal with very little flow throughout diastole. When you have coarctation, you have a delayed upstroke, which is very low velocity, and you have persistent forward flow throughout diastole with no diastolic reversal. So when you see this pattern, no matter what else you see on your echo, this suggests coarctation. All adult patients require cross-sectional imaging to better understand the anatomy. You're looking to see where is the coarctation located. This helps you decide how you're going to treat the patient. Is the arch hypoplastic? Is there an aneurysm of the ascending or the proximal descending aorta? And are there a lot of collaterals, which you see in most adult patients who have a significant coarctation, because that's how they maintain perfusion to the lower half of the body. When we talk about intervention, so we can do either surgery or stenting if a patient has hypertension, either a native or a recurrent coarctation. And so the cutoffs we use are a mean Doppler gradient greater than 20 or an arm to leg blood pressure gradient of 20, recognizing that our gradient might be low if the patient has a lot of collaterals, which are allowing flow to get bypass the coarctation, or if the patient has low output, the gradient's going to be lower, so LV dysfunction or things like aortic valve disease. The decision about surgery versus stenting really depends on anatomic features and patient-specific risks and requires a discussion with the ACHD team, interventionalists, cardiologists, and surgeons. So I want to shift the focus now and talk about those patients who had complex congenital heart disease repaired in childhood. So these are patients who often follow faithfully with their pediatric cardiologist throughout childhood, but when they become adults, they often get lost to follow-up for a variety of reasons. Many times they have a limited understanding of their underlying defect. Some of them might think that they're completely cured. And it's important to recognize that even an asymptomatic patient who has complex repaired disease often has significant hemodynamic lesions, and they really need close follow-up. By the time patients present with symptoms, it usually suggests that they need an intervention, and this really needs to be done in an ACHD center. And arrhythmias are a really common presentation for these patients, and we really need to always rule out structural lesions before we just load them with drugs or proceed to ablation. So I mentioned coarctation, so now let's talk about a patient who had coarctation repaired as an infant or as a child. These patients have a lot of residual issues. Most of them have hypertension. They developed coronary artery disease at a young age and often very accelerated. Many of them will have diastolic dysfunction and secondary pulmonary hypertension. They can develop abnormalities at the site of the repair, either recurrent coarctation or aneurysm formation. I'm showing you here imaging from 3 different patients that I care for. So this patient has residual narrowing and a small pseudoaneurysm. This patient has a very large pseudoaneurysm at the site of repair. And this patient has a hypoplastic arch and a very large aneurysm of the descending aorta. I told you most of these patients have bicuspid aortic valve, and so that valve can become dysfunctional. They can develop endocarditis or endarteritis. They have intracranial aneurysms at a rate 5 times the general population, so we need to screen them with MRA. And really important that all patients with coarctation repair in the past are having regular follow-up so that we're looking after all of these issues. Now let's switch gears and talk about a 23-year-old woman with repaired tetralogy of Fallot. So she had complete repair when she was 6 months old with a transannular patch, and then she had a subsequent balloon angioplasty at 1 year of age. She now presents with atrial flutter and symptoms of right-sided heart failure. Her chest x-ray shows significant enlargement of the right heart, and her transthoracic echo shows free pulmonary valve regurgitation. And I show this to you if you're not used to looking at these echoes to see how this is frequently missed. The pulmonary regurgitation is this red flash. It's very brief, it's very short, and many times if these patients are having their echo done by someone who's not used to looking at congenital heart disease, this will be completely overlooked. If you do read echo, the continuous wave Doppler is a clue to you. You see this very rapid decline and this very dense signal. Now in our patient, in addition to the free pulmonary valve regurgitation, we also saw some obstruction, probably through the right pulmonary artery. You see these 2 different Doppler populations here. So our patient has tetralogy, which is the most common cyanotic congenital heart disease. The vast majority of patients will live to be adults. And remember, tetralogy is defined by a malalignment VSD with aortic override, right ventricular outflow tract obstruction, and then right ventricular hypertrophy. And when these patients are repaired, the VSD is closed, the outflow tract obstruction is removed, and many of them are left with significant pulmonary valve regurgitation. This chronic severe pulmonary valve regurgitation leads to right ventricular volume overload, and we really need to be following these patients. The pulmonary valve regurgitation I've already mentioned is easily overlooked both clinically and on echo. Patients will tolerate it well, but develop progressive right heart enlargement. And we know that if we can intervene with pulmonary valve replacement, that their symptoms will improve, their right heart will get smaller, they'll have fewer arrhythmias and improvement in LV function. But the timing is really the challenge here, because if we start putting valves in these patients when they're very young, we're setting them up for recurrent interventions. And I just want to make this point again for those echocardiographers out there. This is what free PR looks like. It's this very brief red jet. And again, use your continuous wave Doppler if you're confused. So our indications for pulmonary valve replacement, if you have more than moderate pulmonary regurgitation and symptoms, that's a class 1 indication. But we've now moved towards intervening even in the asymptomatic patient. And this is kind of busy, but I have it here for you just to know the things we're looking for. And really the clues are ventricular dysfunction or right heart enlargement. And so we use MRI to follow the size of the right heart in these patients. Surgical pulmonary valve replacement has been the standard of care for a long time. It's the most common operation that our congenital heart surgeons perform. And again, just highlighting the fact that these patients do better if this is done by a congenital surgeon versus an adult surgeon. We typically use bioprosthetic valves, and this sets us up for transcatheter valve replacement in the future. There's now work being done on transcatheter valves for native right ventricular outflow tract in some cases. And really important to recognize there are a number of issues that we need to look for preoperatively in our patients. So anomalous LAD is present in about 10% of tetralogy patients, so really important that we know about this before going to surgery. And then in our patient that I presented, the severe branch pulmonary artery stenosis, because this will require intervention at the time of operation. So in summary, adults with congenital heart disease are a growing population. We really need to be able to recognize those defects that are going to present for the first time in the adult patient, and also remember that the patients who had repaired heart disease usually still have residual anatomic and hemodynamic issues, and even though they're asymptomatic, there are ongoing things that need to be followed so that we can prevent complications. And just making that final point about collaborating care. These patients really need some input from someone on an ACHD team in order to make the appropriate management decision and make sure that procedures are being done correctly. Thank you very much.